Hello. Good afternoon, everyone. And I would like to thank Bangladesh Society and Dr. Kamran Chaudhary Sarji for inviting me to the stage. So today, the topic given has to be is NGS in non-small cell lung cancer and detection to precision therapy. So by profession, I'm a pathologist. I did my MD Path in 2014. After that, I did a fellowship in Tata Medical Center. And since last 6 years, I'm reporting NGS solid malignancies. So this would roughly around 25 to 30-minute session, where I would be discussing more about what is the difference between a molecular biomarker and precision therapy. What is the basic difference between two? Followed by what is NGS, why DNA versus RNA, what does it matter? And followed by how the tissue becomes a very much issue and how to deal with that tissue when you are looking at the lung cancer. Followed by what are the trials and targets. I think it's very well covered. Now, as far as lung cancer is concerned, is more about resistance. Everyone knows that in the first line therapy, TK has to be given. But after that, what? So how long we could extend in terms of target and precision therapy is concerned. Followed by germline in lung cancer. This is one of the newer things had been into the picture since last 2 years. And followed by how AI is changing the landscape as far as molecular part is concerned. So this is a very basic slide. When we all started our medical knowledge, it was always about morphology. And since last 30 years, we are looking at IHC. But now one more modality of investigation is coming into the picture. It is called as molecular. And how it is impacting the patient care. So the basic difference here is that what is a molecular biomarker? We all know that when someone has tell it is a biomarker, it has to fall into either of these three categories. Three categories means something is biomarker, it means it should be diagnostics. Like if you are BCR, ABL, RUNX1, RUNX1, T1. So it's a diagnostic marker, followed by prognostic and predictive. Now what's the difference between a prognosis and a predictive marker? Prognosis means you are telling something is good prognosis or bad prognosis. That's a prognostic marker. But when you tell something to be a predictive marker, you are intervening it and you are changing the course of a disease. So EGFR is a prognostic marker, no, it is a predictive marker, because after something is EGFR positive, you intervene in it by giving TKI and you are changing the course of a disease. So intervention could be in the form of targeted therapy, intervention could be in the form of chemotherapy, or intervention could be in terms of immunotherapy, and you are changing the course of a disease. So that's the basic difference between prognostic and predictive marker. So in solid oncology, it's more of a predictive marker rather than a prognostic marker. So again, as I told earlier, targeted therapy and precision therapy are two different terms. Targeted therapy, it's a blanket, you can give it considering as disease. But when you tell something to be precision therapy, you are adding a layer of investigation. That investigation in the form, maybe in the form of IHC, in the form of NGS, or in the form of flow cytometry. So on the basis of that investigation, you are giving therapy. That's the basic difference of a precision therapy. So that's, and we all know that what is an oncology drug means. So now, just briefing about NGS. Now NGS is roughly around 5 to 6 days process. So whatever block or tissue you send, we extract DNA from that. It's a 1-day process. After that DNA extraction is done, it is gone for a library. And after library sequencing again 1 or 2 days, and finally data analysis. So this is a basic workflow and it takes around 7 to 8 days. So, and how does NGS works? NGS works like a routine camera. We have in our DNA 80 GC sequences. If A, T, G, C, so each sequence or each base pair is labeled with a dye, a high resolution camera takes the image and it is organically arranged. So this is the basic principles of NGS. Now always there is a confusion. When you look at NGS panel, the first, as far as oncologists is concerned, they must know whether it is a DNA based panel or RNA based panel. So if you ask me 2 years, 3 years back, people were doing only DNA. But for any NGS panel, it has to be DNA plus RNA. Why? Because DNA are good for identifying mutations, but RNA is good for identifying fusions. Fusion in the form of ALK fusion, RET fusion, anti-RK. So all fusions are good at picking for when you're taking RNA. But if you do by DNA, then 20% of the times you will miss your fusion. So whenever an oncologist prescribes something, or they want to go for an NGS panel, their first question should be there, whether your panel is DNA, RNA or DNA, RNA both. So the ideal choice is DNA plus RNA. So this is the basic difference why we want to go for RNA sequencing, because technically it is very challenging when you look at DNA to identify it. So next question in lung always arises because it's always a biopsy, very small amount of tissue is there. Now whenever tissue is there, so in this case the middle one is the tumor tissue. Now whenever it is sent to histopathology lab has to understand that now molecular becomes mandatory for all lung cancer. So tissue is an issue. So if you deplete your tissue and at the end of the time that patient would not be given the benefit of targeted or NGS thing. So previously what we used to do, we used to send EGFR alone, ALK by IHC, Roche1 now IHC. But I think now it's a high time since last 4 to 5 years that you should not do individual, because if you start spending tissue and individually, then you would lose tissue and you will not be able to do all the markers. So I am telling the previous one where suppose this is the section. So this is the section where you do tissue, your routine histopath. After you do ALK, after again you order NGS. Then at the end of the time you don't have tissue. So, and in histopathology also, do IHC as less as possible so that it is better for the NGS and the patient could benefit from targeted therapy. So as I told earlier, now it's not a practice to do, it's very rudimentary stage when you say that I would do individual and see what happens. Rather than going sequential treatment, you should do simultaneously everything. So I think it's a busy slide, but just wanted to enumerate that we have come long along since last decade, how targeted therapy is changing the landscape. So these are the, where the gene was identified, and there are more than 200 molecules now available in the market which could be used for targeted therapy. But out of these 200 molecules, which has to be used, that can only be decided by NGS. So just, I have kept this slide, yes, it is of 2024, just to tell you that how within 2 years everything changes. So in 2024, roughly around 11 biomarkers proven were given by NGS. If you ask me, now again as I mentioned earlier, in EGFR also, if there is change in mutation, everything changes. Exon 20 insertion is completely treated differently than your routine EGFR exon 19 and 21. So it's not about gene, it's about what variant you are treating. For example, KRAS. Previously KRAS was non-targetable, but now KRAS G12C is completely different from KRAS. So just labeling it as KRAS is not sufficient. You need to know what another level of deeper mutation it is there. So 2024 almost 11 markers were there. NCC and proven, you could use more it one. But in 2026 it has rose to 16 marker. So I was coming here for this and I was again searching. So one more marker, that HGF receptor one more is added. So the things are changing so rapidly that if you are lag behind 6 months, then also a newer target would come into for clinical practice. So I would not go into much details, everyone knows it. So always question arises because we as an Asians populate most of our data from Western population. So it's completely different here, and region-wise also it varies differently. So just to give a brief perspective, EGFR, Western world 10 to 20%, as mentioned, Madam rightly mentioned in the previous speaker, is somewhere around 40% in here population. Similarly in India Pacific region also, it's somewhere around 60 to 70%, we do get EGFR positive. HER2, now again, HER2 mutation and HER2 amplifications are completely different, even though HER2 name is same. But mutations are completely different from amplification. ERBB2 breast cancer, ERP or HER2 we order, ERBB2 amplification cannot be taken as HER2 or ERBB2 mutations. So again, gene is same, but amplification is one of the genomic abnormality and mutation is alak. So both are treated differently. Both have different set of drugs to treat it. So again, in lung cancer, I'm specifically speaking 2 to 3% frequency, BRAF you still can expect 1 to 2%, and similarly, KRAS, this is just a frequency distribution, and we all know that young non-smoker are more prone to have targeted therapy. So I would sum it fast that how precision therapy, now it's no more a targeted therapy, it's a precision oncology, because you are adding a layer of investigation and you are changing the course of a disease. So it's not a targeted, so targeted therapy could be precision therapy, but precision therapy cannot be always targeted therapy. So that's one of the major difference. So these are the long trials I think Sir would be discussing in the next subsequent slides, where we have, the first column is the mutation, second is the drug. Now 3-4 years back, osimertinib was in the second or third line, but now we have started osimertinib as first line also. Similarly, the third column is the chart which has with the trial like Flora, Mariposa and all that. And you can see that now the PFS and OS of osimertinib like 20 to 38 months. It has changed dramatically in the last decade. Similarly, for each of the malignancies, starting from exon insertion. Previously, if it was on exon 20 insertion, it was not targetable. But yes, again, 8 to 9 months of PFS, you could give it to the patient. Similarly for BRAF, so I would not go into much detail because it's an enumerate list where target therapies have benefit in terms of lung cancer. So similarly for MET exon skipping, if you have positive for MET exon skipping mutation, then roughly 1 year of PFS you are giving to the patient. It makes a lot of difference when you are looking at the overall survival. So again, I want to emphasize more on a gene. So now we all know that EGFR gene is targetable, all that. But just, I have kept this slide here to emphasize, suppose 18 to 21 exons are the most common ones. It doesn't mean that other exons are common, means the less common it should not be targetable. So when it started 10 years back, it was only EGFR 19 and 21. But now many of the mutations, like you can see, have come into the picture, and still, if not first line, many times afatinib is still targetable in that. So now we all know that NGS has to be done. After 1 or 1.5 years, we have given TKI, patient go into resistance. In resistance, another clone of mutation develops. But just, I want to emphasize one more case here, where again, 1.5 years of patient was given gefitinib. After that, again, 1 year patient was given osimertinib. Now patient after 3.5 years had come to us, and it was liquid biopsy. So what we identified, the second line is EGFR exon 19 standard, resistance T790M. Everyone knows that T790M comes in resistance mutation along with C797S. But one more point I want to emphasize here is that now T790M and C797S come simultaneously. Does they have significance? Yes. And the third line which I mentioned is in this patient, cis trans was noted. So there are two things again, when these two mutations come, cis and trans. So if there is cis trans, then this patient will not respond to first as well as third generation there. But if it's trans mutation, then still you can re-challenge it with first and third generation simultaneously. So these are the very few cases report where even if it is the 2 years we have been giving therapy, still you can challenge with a significant TKIs. So now most of us are started using osimertinib in first line therapy. So whenever a resistance mutation is there, the two algorithms should come into the picture. Either it is EGFR dependent or EGF independent, the two initial diversification. And apart from that histological transformation, that adeno is converted to squamous or small cell lung cancer. So I would not go in the next subsequent slide. So when there is EGFR dependent, like I told earlier, T790M, C797S mutation come in the picture. While EGFR independent, another mutation like ULK, RET, ROS started coming. So even it is EGFR, in the next subsequent or resistant therapy will get mutated. It's very rare. So lab becomes very much important that you make sure that it is resistance and it is not false positive. Because as far as NGS is concerned, a good instrument will allow you to be right in report only 80% of the times. Means if you're having good instrument, but at the same time, 20% of the accuracy depends on wisdom and a knowledge of a pathologist or a person who is reporting it. So even having a good machine will allow you to be good up to 80%. And a good, because knowledge is continuously evolving and you need to comprehend the error of machine, error of biology, and still making the context same so that it benefits oncology as well as in decision making for patient care. So this is very busy slide, but wanted to why I have kept this slide is that the first chart is whenever one is first line and second generation TKI used. The top is line second and third generations like osimertinib is used, and the third one is line 1, now osimertinib we are using, third generation is first line. So each time there is resistance mechanism are different. So if you ask, whenever gefitinib or first and second generation are used, 50% of the time you have a chances that you will get T790M. But at the same time, when you are using gefitinib as osimertinib as first line, the chances of having T790M are very less. Other mechanisms like CDKN2A, CD6, CDNN1 amplification are much more common. In the last slide, like 10 to 12%. And somewhere around 12 to 15% of the other targetable mutation. So even after 2 years of TKI, the chances of having another target is roughly around 10 to 15%. So I think 10 to 15% enough good number that you do NGS in resistance mechanism if patient is, unless provided patient is affordable. So in 10 to 15% of the times you will have new target, the clone will evolve itself and still it is targetable. And again. Now this was regarding EGFR. Now each gene we have learned as the faculty we are learning many things. Now previously 5 years back we used to give only EML-ALK4 and it is done. But now EML-ALK4 is not sufficient. We need to give which type of variant it is there. Now, what is this? This is EML-ALK4 is divided again into 7 types. So the top one it is written EML-ALK4 V3AB, E6 and A20. E6 means the breakpoint is exon 6 and AML4 that ALK20. So E6 is the EML4 6 exon breakpoint and 20 is ALK20. So we all know that fusions are a combination of 2 genes. Whether it could be BC or ABL, it could be EML-ALK4. So EML, the breakpoint is 6 exon and ALK is 20. Similarly, EML4 ALK, the variant is V1, where exon breakpoint is exon 13 in EML gene, and ULK gene, the breakpoint is 20. So depending on that, lots of classifications are there. But should we implement it in routine practice? The answer is yes. Why? Because if EML for ULK 1 and 2, the variant is identified, then that patient will behave very good. But if 3A or B, the second one, which is the most common, then the progression-free survival is less. So 2-year survival was 69 to 32%. So it's somewhere around 1.5 years to 6 to 8 months. So it gives you informed call to the patient also that within 6 to 8 months, if it is 3A, 3B, then it would not behave as good as 1A. So prognostically, the answer is yes. Predictive, no. Similarly, after EML for variant as a diagnostic has been identified, after 1.5 years, suppose it's gone into resistance. Now we have lots of, around 10 to 15 ULK inhibitors. So these are the common 5 ones which we're routinely using. So according to the mutation, which drug will respond well, that are also enough evidence. Not mature enough, but still on a decent note, you can act upon it. Suppose lorlatinib is the next generation. At that point of time, most of the times, so even though it is the next generation, still 117S, 1NT will not work great. So again, the level of mutation of resistance would help you to take an informed call that which drug to be selected. Now question arises whether once patient has been diagnosed with EML for ULK. So every patient will develop resistance? The answer is no. Roughly around 20 to 33% only patient would have resistance mutation. So remaining 75% of the patient, you would not have answer or target therapy, or you would have some random mutation like T53 or KIT amplification, even though they are not targetable, but still many of the times you will get answer, and still 30 to 45% of the time you will not have answer. But we are doing it just for remaining 20 to 25% of the patients, how they will benefit it. So we have covered EGFR, ULK. Similarly, Roche is also coming into the picture that initially Roche1 fusion has been diagnosed. And the reason of keeping this slide is that whether in impact, would it make a difference? Yes, for selection of therapy, it would make a difference if you are identifying some of the resistance mutation. So this was all regarding targeted therapy and how precision oncology is changing the landscape of lung cancer. One more thing to emphasize is that this is how, because genomics, now we are learning more. So depending on our understanding, new things are coming into the picture, and that new things should be implemented to clinical practice. So as far as lung cancer is concerned, no one goes for germline testing. For HBOC as well as prostate, we go for germline sequencing. But for lung cancer, we strict ourselves to the somatic testing also. So I have kept this slide just to understand data, because even if you don't go for germline testing, you must be well aware that what are the implications and how much frequency is there, because it's clinician job to, even after patient doesn't do it, that's a different story. But at least you must know what the information is and what the data is there. So this was 7,500 cases of lung cancer. So out of the total 7,000 cases, almost 14.9% were germline positive. Now question arises whether that germline positive will have the treatment implication on the patient. Answer is very less. But to the relative, we need to inform it. So all total 7,000 cases, 15% were having germline mutation positive. It's a very significant number. Now, among that 50%, we all know BRCA1 and BRCA2 are the common ones. So roughly around 2.8% patient of the 100 were having BRCA2 positive. Roughly around 1.2% were having BRCA1 positive. So check to ATM are still less significant gene, but still they are mentioned here. So your every 100 patients, 3 patients would be having BRCA1 or BRCA2. So it will give you information to whether to screen family members or not. And one more point, the second one is that even whether cancer history taking will make a difference, the answer is no. So even if family member has of cancer history or not, the number remains same. It's 14.9 and 14.3. So irrespective of the family history, if you're concerned if patient is affordable, better to go for germline testing. So again, it's the same scenario, the same chart, which more descriptive things, where BRCA2, 7,000 cases, in lung cohort it was 202, as well as proactive cases. And one more thing is that we all know that T790M, T790M do come in resistance mechanism, that after EGFR has been given. So one more it is a germline mutation also. Till 3 to 4 years back, it was not known. We considered that because we do germline, we never do germline sequencing for lung cancer patients. But out of 100 lung cancer patients, total population, 0.9% have T790M germline variant. This is very new for me also. That we consider resistance mechanism. We have labeled it as resistance mechanism, but it is germline. So question arises whether patient is having T790M germline, what should be done? So it is assumed that a normal healthy patient, female, male, if it is having T790M germline mutation in routine screening or as we go for HBOC panel, then 23% chances of having lung cancer is a very big number. So patient should be kept for low dose LD, that low dose CT scan. So that if a lung cancer is there, then you can pick up it at very early stage. And it is more common in females. So this is one of the newer insight which I got, and I think it's very much useful. And whenever you get T790M in your NGS report, you need to look at the VAF. And if VAF is greater than 60, at least you should consider it. And second thing, when you get only T790M mutation in somatic report, it has to be germline. Because generally, as far as clone is concerned, when we have EGFR 19 and 21, then only T790M is there. But if there is only T790M, it has to be a germline. So if any report says somatic, even if you have sent tissue, and you find only T790M, and it is somewhere around 50 to 60% VAF, then I think it's mandatory to do germline sequencing. Because you are because we are going a different way, considering it as lung cancer, and we will treat in that way. So last two slides. So how AI is changing. So we all know that precision therapy. So this is this was again somewhere around 15,000 patient is taken. Just this slide has been kept. It's an off-label from the topic, but how the next subsequent days we would be thinking. Now we all know that we do for clinical examination, cancer staging, pathology. These things are there. So they have taken AI model and they have feed all the parameters, including your CO2 level, everything. And they identified that even for us, PO2 is not significant. But when you look at it as a lung or solid malignancy whole picture, you can take informed decision on the basis of PO2. So this knowledge, we don't have it right now. But because of the data feeding, have come to the conclusion, suppose this case, first line is bony metastasis. We all know that prostate goes through bony metastasis frequently. So this model was able to pick up even in unsupervised learning. So it's a very big breakthrough, and I think in the next couple of decades, we will see many of the things, many of the parameters which we consider as normal, like we would have much significance, considering fever and all that stuff. I think I finished on time. Thank you.